This video is for educational purposes only and is not medical advice. Treatments discussed may carry significant risks and may not be appropriate for everyone. Consult a qualified healthcare professional before starting, stopping, or changing any treatment. Hey guys, my name is Dr. Jack McLean. I'm a board-certified psychiatrist, and today we're going to talk about where different treatments that we use to treat trauma, complex trauma, PTSD, where in the brain they work, and a little bit about how they work. We won't totally cover how they work, but we'll talk about enough about them to give kind of a framework to start tagging information to. And so we're going to use this diagram right here to explain it. And I'm going to go over it real quick, and I think it's going to make sense. But if you want a detailed dive into what happens during a trauma response in the brain, check out my last video, which will appear here if I figured out how to work YouTube. If I didn't figure out how to work YouTube, it probably didn't appear, or it appeared somewhere else. So let's get started. We have a threat, charging bear. That information enters the brain, sent to two places. It reaches the amygdala first because this is a shorter path. A little bit later, it reaches the prefrontal cortex. The amygdala is the threat detection center in the brain. Sees a charging bear, that threat detection center goes off and sends out three emergency signals. Sends a signal to the skeletal muscle, triggering either fight, flight, or freeze responses. Sends a signal to the autonomic nervous system, which will light up the sympathetic nervous system, cause adrenaline to get dumped out in the blood, and result in feelings of anxiety and panic. We'll start shutting down the parasympathetic nervous system and shutting off rest and digest processes in the body. And we'll send a signal over to the HPA axis, which is going to start a chemical cascade that's going to result in extra cortisol being in the blood. This is what we want to have happen when a bear charges, but it doesn't feel nice. The problem occurs after the amygdala has experienced a lot of bear attacks and gets really hyper vigilant. And this process starts to go off really easily. And it's not just bears that can set it off anymore, but you could be at a Halloween party and see somebody dressed as Chewbacca. That information reaches the amygdala before it reaches the logical prefrontal cortex. The amygdala is going to throw the alarm when it sees this big hairy thing walking around. You have a strong trauma response in the middle of the party, and it's a few moments later when the prefrontal cortex can start sending signals to the rest of the brain saying, wait a second, we're not really in danger, that's not really a bear. And that's where you start to see symptoms develop. So again, if you want a way more detailed explanation of that, check out the last video. But let's get started talking about ways we can, different treatments that are available. Okay, guys. I've redrawn the diagram so we have a little more space to work with. But basically what we have going on here is an amygdala that's been through a lot. An amygdala that's had a lot of trauma in the past, an amygdala that's had a lot of bear attacks, and has become hypersensitized. So it takes really small triggers to set off these alarm processes. And we have a prefrontal cortex up here that when there are triggers around, it has trouble communicating with the rest of the brain, passing on information like, hey, that's not a bear, that's Chewbacca, and letting the rest of the brain know that we're actually safe right now. And so when we're looking for treatments, when we're looking for things that might help, what we want to find things that can turn down the volume of the amygdala a little bit, and we want to find things that can turn up the volume of the prefrontal cortex a little bit. Quiet down the alarm and wake up the prefrontal cortex. And possibly some stuff that could work farther down in the chain too. And so let's start looking at things that are used. The first one I'm going to put up is not recommended, and that's alcohol. It's probably the most commonly used substance to treat the results of trauma in the nervous system in the world. And if we were to graph, in fact, let's just do it. If we were to graph how likely you are to be diagnosed with an alcohol use disorder, that's his alcohol right there, versus how many adverse childhood experiences you had, or essentially types of childhood trauma you had. The graph doesn't look exactly like this, but it looks pretty close. And so what we see is the more different types of childhood trauma a person had, the more likely they are later in life to be diagnosed with alcohol use disorder. Why is that? Well, the person with a lot of childhood trauma probably has an amygdala that's been hypersensitized and sets off its alarms really, really easily. Alcohol, this is a minus sign, Alcohol initially does a really good job of quieting down the amygdala, of quieting down this alarm. This alarm that, when it goes off, it really can cause a lot of suffering. And so for a while, it often works. In the long run, it almost always causes more suffering than it relieves because over time, the brain builds up tolerance. It takes more and more alcohol to quiet down the amygdala. It damages other parts of the body. And up here at the prefrontal cortex, it does the exact opposite of what we want. It also quiets down the prefrontal cortex, which leads to poor decision making, which often leads to more trauma, which leads to an even more hypervigilant amygdala. So in the long run, alcohol almost always causes more suffering as a strategy. But it makes sense why people turn to it, because they're trying to treat the results of trauma. We could pretty much draw all the same stuff if we looked at opiates as well. And so why I erased this, I'll give my little editorial. If you're working with or if you're treating an alcohol use disorder, an opiate use disorder, take some time to figure out if at the same time you also need to be treating trauma. The next category I want to put up is sometimes recommended. And these are the most common medications used to treat trauma. And those are SSRIs, or selective serotonin reuptake inhibitors, and SNRIs. Selective norepinephrine reuptake inhibitors. Now, these are both groups of medications called antidepressants. It's an absolutely terrible category name. They are used first line to treat depression, but we also use them first line to treat generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder. We use them first line for a lot of things because they have the very best evidence for a whole lot of different things. And so it's a little bit of a clue that all these disorders maybe aren't as separate as the diagnostic manual seems to suggest they are, and have some things in common. But these are by far the most commonly prescribed medications for trauma. And the reason why is because they do exactly what we want, at least a little bit. They quiet down the amygdala just a little bit, and they wake up the prefrontal cortex just a little bit. So they make the alarm a little bit quieter, and they make the part of the brain that can look around and say, like, oh, wait, we're actually safe now. They make it a little bit louder, right? Now, you may, say like, hey, I've taken Prozac before, I've taken Lexapro before, and I still had PTSD symptoms. With significant trauma, complex trauma, it's rare that an SSRI completely takes care of everything. But in a lot of people, they will help some, and combined with other types of treatment, can result in sometimes enormous benefit. And so for some people, they can be a really important part of treatment, and this is why. The next category I want to put up is a little bit of a weird one for a psychiatrist to talk about, and this is blood pressure medications. And there's three I want to mention. And those are propranolol, clonidine, and prazosin. And let's just go through and talk about each of them one by one. So propranolol is an old blood pressure medication used to treat hypertension. And it's really commonly used in treatment of trauma. It's a type of medication called a beta blocker. And so a lot of people have heard that category name. But what it means is it blocks beta adrenergic receptors, or a simpler way to say that is it blocks the beta type of adrenaline receptor. And so we have adrenaline receptors all over our body. When adrenaline touches that receptor, it speeds things up. When adrenaline touches a receptor on your heart starts beating faster. And this results in a lot of the feelings of panic and anxiety that adrenaline can cause. Well, propranolol covers up the beta-style adrenaline receptor, so adrenaline can't hit that button. It can't make the receptor do what it would normally make the tissue it's on do. And so we can think of propranolol as working right here and kind of blocking adrenaline from being able to work. And so propranolol often will help with symptoms of anxiety and trauma in the body. Like essentially, there can still be a trigger, there could still be a bear or a Chewbacca, the amygdala could still light up, the sympathetic nervous system could still light up, adrenaline could still be poured out into the blood. but the person who's taken propranolol before the trigger occurred is not going to feel that adrenaline as strongly. They're not going to feel as much panic or anxiety in their body. And so it can be a really useful medication, especially for physical symptoms of trauma or physical symptoms of anxiety. The next one I want to talk about is clonidine. It's another old blood pressure medication. It works a little different than propranolol. And so if you were to look up a textbook or pick up a textbook, it would say something like, clonidine reduces sympathetic outflow from the central nervous system. And basically what that means is, the amygdala goes off and it shoots signals down the sympathetic nervous system to the rest of the body. And you actually have two chains of sympathetic nerves that run down either side of your neck, from out of your brain, down your neck, into every organ in your body. And this is what speeds everything up and causes the release of adrenaline and so on. And what clonidine does is it turns down how loud that signal is just a little bit that's coming out of the brain to the rest of the body. And so we could think of it as working right here. Just slightly quiets down this sympathetic nervous system signal that's coming out. The third one I want to talk about is prazosin. It's not a beta blocker, but it's something called an alpha blocker. So it blocks the other style of adrenaline receptor. And it's most commonly used for nightmares, which are a super common symptom of PTSD. And whereas we can think of propranolol as working more out in the body, we can think of prazosin as working more in the central nervous system. And I'm not going to be able to draw up where the locus coeruleus is and where prazosin works in the brain. But we can think of prazosin as kind of working more in the brain and helping with things like primarily with nightmares. Someone may leave in a comment, propranolol and prazosin technically both work in both places, but you really notice the effects of propranolol more in the body and prazosin more with things like nightmares. And so it's often taken at night before you go to sleep. This is also an important place to maybe reiterate the disclaimer at the beginning. I'm only talking about a handful of benefits of these. I'm not talking about all the dangers associated with these meds. For instance, if you have asthma and you take propranolol and you have an asthma attack and you try to use your inhaler won't work as well. Or if you mix propranolol with these other two blood pressure meds, it can be really dangerous. And so it's super important that you don't make any medication changes without talking to your doctor. And really, picking medications is so individualized. It really needs to be done with you and somebody who's taken a really detailed history. Because there's all kinds of reasons why something would work for most people, but it wouldn't work in one specific instance. So let's go into our next category. And the next category is going to be an awkward three-lettered things I've thrown together. We're going to put TMS, SGB, and KET up here. TMS stands for transcranial magnetic stimulation. This is something that's not FDA approved for PTSD, but it's not uncommonly used for PTSD, and there's plenty of people who report benefit from it. And what they do is, in your first session of TMS, of transcranial magnetic stimulation, they spend a long time dialing in where they're going to send a little electrical impulse. So you're sitting in a big dentist chair, they've got this giant magnet thing up there, and they spend a lot of time finding just the right part of the brain to aim it at. And they normally aim it at a portion of the prefrontal cortex, and it sends a small current into that portion of the prefrontal cortex. And so this is a plus sign. We can think of TMS as helping to wake up a portion of the prefrontal cortex. Just as an FYI, this is totally different than ECT or electroconvulsive therapy. Very, very different treatment. The next thing I want to talk about is SGB, or the stellate ganglion block. Now, this is a really old procedure that's relatively new in catching on as a treatment for PTSD and trauma. And so what it is it sounds scary. The stellate ganglion block, remember I mentioned before, there's sympathetic nerves that run down either side of your neck that carry this sympathetic nervous signal from the amygdala to the rest of the body and result in adrenaline getting released and everything speeding up in the body. And the stellate ganglion block, a doctor finds this bundle of nerves, a bundle of these sympathetic nerves called the stellate ganglion, and they inject it with a numbing agent, like something you'd get at the dentist, like lidocaine, right? And they do this under image guidance, so they're not just guessing where the needle goes. They use either ultrasound or fluoroscopy. And what that results in is they block a portion of this sympathetic signal. leaving the brain and going down to the body. It's very off-label for PTSD. There's a couple of small studies that support its use. It's been used a long, long time for certain types of chronic pain syndromes, especially neck pain and shoulder pain and things like that. And it's something that's really been catching on a lot in the last few years. And I can't wait until more and bigger studies come out on it. Anecdotally, what I've seen is about a third of the people I've sent to get stellate ganglion blocks came back and told me, they're like, this was a game changer. I can't believe how much safer I feel, how much calmer I feel in my body than I did before. About a third of the people I've sent have come back and said, yeah, it was okay. It helped a little bit. And about a third of the people I've sent came back and said, that sucked. They stuck me in the neck with a needle. I paid X amount of money and I don't really feel any better. So not recommending it, but it is something that is gaining popularity and is worth knowing about. The last one, ket or ketamine, is going to be, we'll do a whole nother video on it. It's too big of a topic to talk about by itself right now. And it's more and more commonly being used to do trauma work, and it can have some real benefits, and it can also have some real negative effects too. The last category I want to put up here is the most important one, and that's therapy. So studies of therapy have shown where you scan people, when you scan people's brains before therapy and you scan them again afterwards, it does exactly what we want. It quiets down the amygdala some. The volume of this alarm signal is not quite as loud, and it can help wake up the prefrontal cortex some, make it easier for the prefrontal cortex to talk to other parts of the brain and remind other parts of the brain, like, hey, wait, that happened in the past, we're actually safe right now, or hey, wait, that's Chewbacca, it's not actually a bear. And one of the ways we think this happens is there's been some other cool studies that have shown that after a course of therapy, you can actually find physical changes in the brain. And you can see pathways coming out of the prefrontal cortex that are thicker than they were before. And it makes it essentially easier for the prefrontal cortex to talk to other parts of the brain. Now, there's a ton of different types of therapy and a ton of different types of trauma therapy. We'll do another video on that. We'll just do a whole nother video on all the different types rather than try to get into it right now. So I think that's all I want to cover for the moment. Thank you so much for watching. Please leave me a comment if you have questions, if you have other things you'd like to see covered in the future. Please like and subscribe, it really helps. And yeah, thank you so much for watching.